Hello. So now we're getting into all of the assessing tear things. And the books I used for this was mostly Anne Fry's Healing Passage. It is chock full of all of the things. And then also the blue Midwifery Skills book again. So most of this information comes from there. So tears, trauma to the cervix, vagina, labia, and perineum can increase blood loss, cause increased pain for the woman, possibly lead to long-term morbidity and result in infection. So we should examine the woman's genital tract following the birth to ascertain the degree of trauma and whether repair is indicated. That's the blue book. Very technical, but you get the point here. It's a good idea to take a look and just see what's happened and what degree of trauma there is and if repair is needed. The rate of detection increases if perineal trauma is examined for twice, either by two separate midwives or doctors, if no suturing is required or prior to suturing. And, I'm sure this is true with so many things, but yes, I agree here, and I think that it was a good idea and great practice to have two people examine perineal tear or perineal trauma to see if, maybe one person finds something else that someone else missed or has a differing opinion. It's great to just have two sets of eyes rather than one. And then I would add to that is even including the mom in this. So having a mirror, having it available so that she can look and assess her own degree of tearing along with you, or at least knows relatively what you're looking at and what's going on with her own body. But I don't know that I would necessarily count that as the second set of eyes. I think in some cases, it's great to just get two opinions on the same thing. So here's a video, and of course I'm trying to nurse a baby, and it's late, and I've been studying this stuff all day long because I'm a birth nerd, but here's a video. Hold on, looks like I'll have to put it on my hotspot to do it. Okay, it's not working. I'll add the video at the bottom. It's so good. It literally tells you exactly how to do this and demonstrates very well by a midwife. Really wish I could just open it. That would be cool, but I can't seem to do that at the moment. So I'll just have to link that separately and watch it on your own. If you need to pause the video here, go watch that video so you know what I'm talking about here and have an example of what this could look like. So this is from Ladybird PT, and this shows the different types of tears and places for tearing. Mostly you hear about graded perineal tears, first degree, second degree, third degree tears of the perineum, but there's also labial tears, these ones that are more inside, periurethral, periclitoral, and there can even be ones inside and behind and all of that. So labial tears refer to the labia minora, typically could be both or one or the other. The sulcus, how do you say that? Sulcus and vaginal tearing. I would call that vaginal wall tearing, the upper vaginal wall, in absence of a grade 3 or 4 perineal tear. So something that's just maybe along the sides inside. With that said, folks can experience tearing of the vaginal wall at any level. So it could be more significant even if it doesn't include the perineum. Periurethral, that's ones that occur in the opposite direction of perineal tear. So they're more, rather than tearing down towards the anal opening, it would be up top towards the urethra. Clitoral and periclitoral tearing occur in the same direction as the urethral ones, so they go up towards the top, tearing next to the clitoris. For the timing of inspection and repair, a tear is usually not a life-threatening problem. Therefore, if the mother is stable and not continuously bleeding, it's important to allow uninterrupted time after the birth for the mother and baby to connect and allow the mother to deliver her placenta. Ideally, at least 1 hour is allowed for this quiet, sacred time. The first several hours following birth have been recognized as a sensitive period when certain genes, keys are related to attachment are being turned on in the baby's DNA. Once these precious, irretrievable first minutes have passed, be sure all of the following questions are satisfied before you inspect the perineum. So asking yourself and checking these out, are mother and baby stable? Is the placenta out? Is bleeding normal and under control? Is the uterus low and firm? Has the mother been hydrated, cleaned up, and moved to bed? Has the baby nursed? Has the bed been tidied? Does the mother feel ready to be checked? So this is usually taking place, after she's birthed the placenta. You're asking, would you like to get comfy in bed, get in the bed already, getting her settled, and, seeing the stability of mother and baby, the bleeding's normal, tidying up, they're nursing, all the things. The timing of inspection and repair is dictated by the needs of the individual situation. The need to leave mother, baby, and partner alone to bond should always take precedence over our own desire, your desire to get everything done and cleaned up. However, if the mother is to remain at home and you believe a repair will be needed, you must also take into account your fatigue level and how much the mother is swelling from the trauma of birth when deciding how to proceed, and when to time this. That's a very real thing, getting super tired after a birth. If you've been up 20 hours at this point and you're getting really tired, it may become more and more difficult to make these very detailed assessments given your fatigue level. So taking that into consideration with the timing, as well as balancing this desire to hold mother and baby so sacredly, but also honor yourself and your own limits of what you're realistically able to do. And that's why it's also great to have another person, assistant, or someone else who can also support these things. While you're waiting to examine the mother, you can give her at least 1 dose of oral homeopathic arnica to minimize bruising and swelling. Since every woman has some tissue trauma from the stretching of birth, it's reasonable and a safe precaution for the immediate postpartum. So to do that, you would just administer 1 pellet of 30C arnica every 10 to 15 minutes after birth, as needed and desired by the mother. As you move into the second hour, arrange the mother so that you can and her together inspect the perineum while she focuses on the baby. The baby should not be physically separated from the mother unless it is absolutely unavoidable for as many of the first 6 hours after birth as possible. So keeping mom and baby together and preparing to do the examination, usually by getting her settled in bed, and creating that beautiful bonding with baby. When you examine the perineum, should you find yourself unable to identify landmarks or are sure the damage is beyond your skills, in the ideal circumstances, you should wait no longer than 6 to 8 hours, the golden period from the time of injury, to make other arrangements and have the repair completed. Speaks for itself. Thank you, Anne Fry. While this timing is ideal if you feel incompetent to perform the repair or it takes more time to arrange for another practitioner to do it, it is comforting to know that from this study of 2 groups of women, 78 of whom had their torn sphincter repaired immediately, and 87 of whom had a delay of 8 to 12 hours before having their sphincter repaired. They found no significant difference in rectal incontinence between the groups. In fact, the delayed repair group had a slightly lower rate of problems. So yes, this is a vote in the camp of when in doubt, just seek another opinion and maybe have this repaired. But you have time, even if initially, let's say the second examination didn't happen, or if there was uncertainty within those first 8 hours, still a repair that is delayed for 12 hours, there's not significant difference. But, those early hours are crucial, and making the decision, within the first 12 hours is ideal. So just something to take into consideration and remember when you're checking these things out. So here's 2 photos from Anne Fry about examining either with one hand and parting the labia and opening so you can see. And usually you'd need an assistant to hold a really good light so that you can see inside. And then an example of using 2 hands and spreading that way so that you can see internally. And for the most part, you should be able to see internally here, even to look inside. There's actually a lot in view on both of these. But if not, then that video covers checking more detailed internally. Grading. First degree involves the yoni and the perineal skin only and should not be identified by a location. The tear is shallow at each apex and does not involve perineal muscles. This type of tear you'll see the most frequently. It includes very minor damage such as abrasions, skid marks, and skin splits, and other shallow tears, many of which do not require repair. Second degree involves the muscles of the perineum. A complete second degree tear extends through the muscle fibers of the perineal body, but does not involve the anal sphincter. Third degree involves injury to one or both of the anal sphincters. If there is any doubt about the grading of the tear, then just automatically give it the next highest classification when describing any type of anal sphincter injury. When in doubt, just go to the next one. So the subcategories are as followed. 3A is a tear that involves less than 50% of the thickness of the external sphincter. B is a tear that involves more than 50% of the thickness of the external sphincter. And then 3C is a tear that involves both the internal and external anal sphincter. And then officially fourth degree damage includes third degree damage as well as disruption of the anal mucosa. Tears that only involve the anal mucosa with an intact anal sphincter complex, a butthole tear, should be classified as fourth degree with the actual injured parts described in detail. They do not refer to tears in the anterior or lateral yoni walls or to tears in the labia or periurethral tissues. Those sorts of tears could be classified as either first or second degree based on your best guess as to whether they involve the muscle tissue. However, there's no provision for classifying odd tears in the perineal area, for example, one that includes the yoni mucosa, sphincter, and anal mucosa, but are very shallow, that there is no other perineal muscle involvement. So lots of variation here. And yeah, I can see why getting a second opinion is great. Especially being newer at this, it's like I'm not exactly sure what I would be looking at all the time, and probably would need a more experienced eye to be able to tell the difference between like a 3B and a 3C and fourth degree, and then especially the ones that involved The anal sphincter, you know, sounds like more serious and would need a second look, just in terms of my experience level. And I've not done a lot of repairs, so a lot of these I would not be able to repair and would need a higher level of care. So, some considerations that might make you lean towards suturing. The woman wants suturing. The woman is concerned about a good cosmetic result. She wants it to look a certain way or, appear similarly to before. There's a second, third, or fourth degree damage. The wound is ragged. Of course, I say raggedy, ragged or oddly shaped. The edges of the wound do not meet when the legs are together. If it's deep or extensive internally or externally, if it hangs away from the vulva in a chunk, or the wound is bleeding excessively. Some circumstances that might sway you in the other direction towards not suturing would be the woman refuses sutures. She has adequate ongoing support at home and can realistically manage to stay in bed for 2 to 3 weeks. The tear is short and shallow throughout. The edges of the tear are straight and lie together. The tear is a long and old scar that was painful even after healing had occurred. So like if she's torn there before, perhaps not repairing it again. No more than 2 stitches are needed to close the tear, or it's just not more than 2 centimeters long. Um, the periurethral or labial damage has not left chunks hanging and is not bleeding. You're quite certain that the rectal mucosa and anal sphincters are intact. Circumstances that call for transport to the hospital for repair or consulting with another practitioner with more suturing experience. The landmarks are not obvious, or you're not entirely sure what structures are damaged. The tear is quite a bit more extensive than you have repaired before, or you're uncertain with your skills, and this could be even just diagnostic and classifying them. You do not have the appropriate materials or equipment to do the job. There's extensive tearing deep in the yoni that requires retractors to repair properly. If there's extensive cervical tears, you can't locate the apex of a tear. There's bleeding that's uncontrolled or the source cannot be identified. Repair requires dissection of intact tissues. There is an upper yoni wall tear. The anal sphincter or rectal mucosa damage, blood in the urine upon catheterization that could indicate involvement with the urethra. There is, or you suspect, an extensive or expanding hematoma. There is a deep or extensive periurethral damage, especially near the clitoris or urethra. So all of those would just be a call, and you wouldn't have to think too much about that. Just um, seeing stuff like this is a good reason to call for more help. So, more experience will eliminate some of the considerations, but one of the most important characteristics of a good midwife is humility. If in doubt, transport or call for backup. And I definitely find this true just in a very short amount of time of assisting with births, that it's better safe than sorry, and to always err on the side of caution. And maybe because tears are often either missed or underestimated. Even in the research, they're typically underestimated, to err on the side of caution and maybe overestimate them rather than underestimate them. But that always the decision rests with the mother. So, doing your best to convey all of the information, take your time, have 2 people look at it, um, give informed decision making around what you see, either you're not able to see or you're unsure about, and make your recommendations along with how the mother's feeling and what her concerns are and checking back in, even if you feel like you have covered your bases there, I think, you can always check back in with the mother, even in an hour, 2 hours, a couple hours, and see how she's feeling. Maybe her thoughts or feelings have changed, maybe yours have. Um, I think, especially being new, you make mistakes and you always learn. And so I think this is one of the areas for growth for a lot of people, including myself, is to continue learning about assessing these tears because there are so many variations in this. And yeah, just erring on the side of caution, listening to women, listening to their symptoms and their experiences, and doing your best to make an assessment here, and then refer out for more care when you're not too sure. So, thank you for joining me on that journey through assessing these tears. I am learning so much and eternally, constantly humbled on my knees, begging for grace and mercy as I continue to gain more of these skills. So, yes, I'm open to feedback and resources and all the things. And I definitely appreciate times when I can ask for more support around this or reach out for a second opinion to more experienced birth workers and midwives. And even if there is a transport, being able to communicate appropriately what the concerns are and your assessment of the situation can be so helpful for the families getting the support and care that they need, even if it is outside of what you're capable of. Thank you.